Okay, welcome. So over to you, Miss Richardson. Let me just share my screen. There you go. Right.
Great. So hopefully can everyone hear me?
Yep. No.
Great, that's good. And can everyone see the slides? Yeah. So as it says on the tin, it's this is all about retinal emergencies. And initially I thought that was quite a big topic, but actually, if you think about the topic of emergency, I mean, I would define emergency as must be seen that day, rather than must be seen in 2 weeks. So we can rule out quite a lot of retinal conditions as urgent, yes, but not emergency. So if I could perhaps have the next slide, please, Bavina. So retinal detachments, we would count as an emergency. Macular on detachments are the most urgent because we want to preserve the macula being attached. We would see those within 24 hours. And please, a plea to everybody, Queen Mary's and Denmark Hill do not accept walk-in patients. However urgent you think your patient is, please do not send them as a walk-in. All that happens to a walk-in patient is that we may say, oh, lovely, you're here at 10 o'clock. We've got an appointment at 3. So you can go away for 5 hours, or you can sit here for 5 hours. So please don't do it. Please don't send anybody as walk-ins. We do not accept walk-ins. Just email them. The consultants are I mean, I'm triaging. The consultants have a rota for triaging the emergencies, and we are triaging constantly. So, we're always looking at the emergencies. And if we see something urgent, like a macular on detachment, we'll be emailing the booking team and saying, get them in now. So don't have any fear about that. Macular off detachments, we also try to see Sajid, we'll put the email address. I mean, I'm sure Bavina's got it. I can send it out to you as well. Macular off will also be seen the same day if we can. Now, retinal tears is a particular bugbear of mine because we've had some very, very poor referrals of retinal tears. And in fact, myself and my ST2 Maya audited the referrals for retinal tears. I'm sad and disappointed, and I'm sure you'll be sad and disappointed to know that the accuracy of referral of retinal tears, the MECS optometrists were no better than the non-MECS optometrists. There was a real correlation between people who noted that there was Schaefer sign positive and actual positivity of having a retinal pathology. And the other thing that we found rather tricky is that I know everybody's bought Optos and Optomaps, but we really, you have to familiarize yourself with what a normal retina and the variants of normal look like on Optomap. So we had a lot of referrals for, is this a tear? Is this a tear? Based on just an Optomap. Following the audit, I spoke and with Matt and also with Joe, and we decided that, poor referrals will just be rejected to go back to you. We would expect, certainly from a MECS optometrist, that a patient with a query retinal tear has been dilated and a comment on the Schaefer sign, because we need to know we can't see the volume otherwise. We need to see the people who really need us. It really is important, and they will be rejected if you don't do that. Particularly referrals with just an Optomap saying this is an abnormality. That's just not going to be accepted. So you have been warned. If you could go on to the next slide, please, Bavina. So here you can see, this is a picture from Sami Habal, one of our VR consultants, and you can just see a shallow detachment there, shallow detachment affecting them, coming down and affecting the macula, supratemporal detachment, nice and not a classic, deep rippling effect, but you can just see the ripples in the periphery, and it's coming down into the macula. So next slide, please. And then again, this is Sammy's before and after. So before is on the right, and you've got a nice detachment there. You can see it very clearly, a big detachment with hemorrhage in the vitreous. And then after vitrectomy and cryotherapy, you've got a lovely flat retina with a nice big cat cryo scar. So it does work. What we do does work. So next slide, please. So just a little word. I mean, tractional retinal detachments. I haven't got any pictures of tractional retinal detachments. Those are usually, as you all know, seen in diabetics, where you have fibrovascular traction from new vessel complexes, causing traction on the retina and literally pulling the retina off. It's what caused blindness in diabetics before we had laser. Tractional retinal detachments really aren't an emergency. They're an urgent VR referral because they require a vitrectomy, delamination of the membranes and splitting of the membranes, because what you've got to do, if you imagine a piece of elastic attached to a sheet, you've got to cut that elastic in order to get the retina to go flat. So if you think there's a tractional detachment, and a tractional detachment, rather than being bullous and curved convex towards you in coming into the vitreous, is more a sort of concave pattern. If you think you've got a tractional detachment, refer urgently to VR and we'll do the rest. You can just refer via our urgent email. We'll put it through to VR. You know, we can redirect our referrals where we want. This is a serous detachment in a patient with posterior scleritis. And a serous detachment, you just see almost like a gigantic CSR. So just imagine a CSR that is really large. So this patient has actually got posterior scleritis affecting around the disc, and they've got swelling of the extending across into the macula there. So next slide, please. So this again is an OCT of a serous detachment, and you can see what I mean by it looks like a gigantic CSR. So there's no holes in this retina. There's no the process is coming from underneath. It's coming from either from the disc being swollen as in scleritis, and you've got the swelling and effect of the sclera, or you've got you can get serous detachments over melanomas and over metastasis. So if you see a serous detachment, that is at least urgent. I would no one is going to mind if you said that in as an emergency. We would not mind at all, not even slightly. So this is what this patient, this is one of Laja Sharif's patients with posterior scleritis, and this is what they look like when they presented. And with the next slide, you'll see what happened as Laja treated the patient. So this is after steroids. So it's just melting away, just melting away. So unlike a CSR, which might get worse with steroids, you may need steroids in a serous detachment, but obviously it depends on the cause of the serous detachment. And the worry always is there a mass underneath that? Not in this case, as you could see that when you looked at the posterior pole on the colour picture, it looked pretty nice, but sometimes you can get a nasty mass underlying a serous detachment. So just beware of those. So if we could move on, Bhavina. And here is one such patient. So this patient, I kid you not, this patient was referred by an optometrist as macular edema. And I took a look at the OCT and the picture, and I went, oh my God, and get the patient in. So I'm sure no one here would think that this could possibly be just simple macular edema. So you've got a huge elevation there across the posterior pole, and suffice it to say that this lady had a mass underneath it. This lady has breast cancer, and she had a choroidal metastasis underneath the serous detachment. So that was not an easy conversation to have in eye casualty, but it was an eye conversation we had. She knew at that stage, unfortunately, she had metastatic breast cancer. So obviously the next step for us is to contact her oncologist as quickly as possible and say she's got metastatic breast cancer. And we would also refer as a backup to Moorfields Oncology, just so that they would see the patient as well. I think you'll find the next slide is either her OCT or her post-treatment. Yeah, this is the OCT. Now, this is the OCT that was sent to us as macular edema. And you can see that's not macular edema. You can see to the right-hand side the great big elevation of in the choroid where she's elevated with her choroidal metastasis, and the serous detachment over the top. And then the next slide is her after treatment. She had some treatment. Oh, no, that's sorry. So no, I didn't give you that one because it just looks very nice. So the next slide is about central retinal artery occlusion and branch retinal artery occlusion. We would consider those an emergency. The reason we would consider those an emergency is because we consider them to be strokes. So we would want a patient to go down the stroke pathway quickly. From the point of view of treatment, people always get very itchy and excited about central retinal artery occlusions and, you know, can you blow in a bag or give them a Diamox or massage the eye? And you can try all of that, but only within the first 4 hours. After that, you've had it. The retina is just ischemic and it just can't cope. You won't, you know, whatever you do, you're not going to shift it. The problem and the other reason that is so important we need to see these urgently is because we want to refer down the stroke pathway, but we also have to rule out giant cell arteritis because giant cell arteritis is a horrible blinding condition. And if it's not treated promptly, you can go from 6/9 to NPL irretrievably. And it's a really nasty condition and bilaterally. So giant cell arteritis, as I'm sure you all know, is a condition you will never get giant cell arteritis in somebody under 50. I have had 35-year-olds referred in. They will not have GCA. So GCA is a condition where classically you would expect to have temporal tenderness, temporal headaches. You might get jaw claudication, and the way to ask about jaw claudication is to say, if you eat a beef stew, does it hurt when you chew? Because it's short, you're getting cramp in the muscles, in the masseter muscle when you're chewing, and you can get night sweats, loss of weight. But if you suspect GCA, if you see a central retinal artery occlusion and the patient says, I've got some pain here, send them in quickly. But don't send them as a walk-in. Never send them as a walk-in. Just send the referral. We will act on it. Trust us. We will act on it. All right. So that's central retinal artery and branch retinal artery occlusions. We would treat exactly the same. The next picture just shows a lovely small branch retinal artery occlusion there, just coming into the macula there for the patient. Beautiful picture. So you're expecting to see on the OCT, you're expecting to see intraretinal edema, not cystic swelling in the macula, but intraretinal edema. So the retina looks thickened in that area and subsequently will thin. So next slide, please. Diabetic retinopathy and central retinal vein occlusion. I spend a lot of my life seeing diabetics and central retinal vein occlusions, but I wouldn't count either of them as an emergency. You can refer them in and we will see them, of course. The only situation in which we would consider they are an emergency are either diabetes or central retinal vein occlusion with rubeosis and a raised intraocular pressure, because obviously you don't want to be sitting around with a pressure of 60 for a while because it's not going to be very good for your optic nerve. And vitreous hemorrhage in a treatment naive eye. Now, by that, I mean, if you're seeing a diabetic patient in practice and the patient has had a vitreous hemorrhage and you say to the patient, have you ever had any laser? And they say no, then that is an emergency. The reason for that is just because they're diabetic doesn't mean they haven't got a retinal tear underneath the blood. Last week, we had a patient referred in with a vitreous hemorrhage. She was seen in casualty. They couldn't see a tear, brought back to the VR clinic. In fact, brought back to Sami Habal's theatre list because Sami was downstairs. So he said he'd see the patient whilst between operations. Saw the patient, saw a nice tear with a start of a detachment. She had an immediate vitrectomy and laser. So the reason we're seeing diabetics with vitreous hemorrhage who have never had PRP as an emergency is because you can't assume that that's diabetic disease. So if you see a diabetic who's had loads of burns in the retina and they've had a vitreous hemorrhage, we will see them, but they're not an emergency. We would usually get those into the vitreoretinal clinic so they can have a little look at them, decide when and where to operate on them. But they're not an emergency. Those are the only two emergencies in diabetes and CRVO. So next slide, please. Macular degeneration is not an emergency. It's urgent. We all know it's urgent. We want to treat it. But it's not, please don't send these patients to emergency. It's so unkind on them because they're elderly people. They're desperate, they're worried, they're frightened, and they come to casualty. And then you say to them, right, yeah, you need to go to Mrs. Richardson's clinic or Miss Sharif's clinic, or this is not the place for them. They need to come into a clinic where they can discuss with the consultant, and finally make a diagnosis, if necessary, do OCTA, etc. And then we would treat them accordingly. So please don't send macular degeneration as an emergency. Definitely don't send them as a walk-in. That is so unkind, because I've had 85-year-olds get taxis to eye casualty, and it's just unkind because they won't be treated on the day. It's not an appropriate place in eye casualty, and they'll wait for 4 hours for somebody, for a junior doctor to say, yeah, lovely, you need to come to the MedRet clinic. So we just refer via the rapid access service or via the urgent inbox, and we will do the rest. So next slide, please. Now this is an emergency, and it's not very common, but I thought in the interest of it being retinal, I'd show you. So this is acute retinal necrosis. So you would suspect this in a patient with a pan-uveitis and with hemorrhage or white patches in the retina. This is an emergency. The reason for this is that once, if you read the name of the disease, this is retinal necrosis. And if your retina necroses, that's it. You lose your retina. So you want to stop this in its tracks. The commonest causes of ARN are probably zoster. Herpes zoster is one of the commonest. Herpes simplex. In the old days of when we first used to see patients with HIV used to get devastating acute retinal necrosis from CMV retinitis, and it was really a horrible condition. But fortunately now, with the advances in the treatment of HIV, I'm pleased to say that juniors these days don't see what I saw. So we have got I've got some nice pictures from NEDA of acute retinal necrosis. So if you could go to the next slide for me, Bhavina. So there you can just see out towards the periphery those white lesions in the retina. It's a disease that usually goes along the arteries, but if you see patches of white in the periphery like that, in someone with a pan-uveitis, then you send them quick to us and we will do the rest. So those sorts of patients, they may need a vitreous tap if we can't see the fundus clearly, and then they will need prompt intravitreal and systemic antivirals in order to treat this. You can treat it, and you can treat it well. So if we could go to the next slide, please. So again, though you can see lots and lots of white lesions there, some hemorrhage out inferiorly. That's again a sort of disseminated arm. And you can see how white the blood vessels are as the retina starts to necrose in the periphery. So next slide, please. And I think Neda decided to get in on the act because she couldn't be outdone by, no, I think this is Laja's rather than Neda's. So again, this is very typical of ARN. So again, big white lesions, lots of hemorrhage on the edge. If you see those, press the panic button immediately, send the patient immediately. Fortunately, I'm pleased to say it is not a common condition, but in a pan-uveitis with white and red in the fundus, send it straight away. So next slide, please. Toxoplasmosis, again, not a very common condition. And toxo, you get a posterior uveitis. And what you're looking for, we've all, I'm sure, seen chorioretinal scars from patients who've had toxo, but you're looking for the fluffiness of the edge of the scar, which indicates activity. When it's fluffy and indistinct, it's usually unilateral. And it's only an emergency if it's threatening the fovea. Having said that, I don't think anyone, least of all Larger or Neda, would get cross if you sent one in to eye casualty. But if it's threatening the fovea, we need to see it and quick. So again, go down the emergency pathway, just send us an email, we will triage it quickly. So I think Larger sent me some nice pictures of toxo. So this is toxo. You can see the scar inferior temporally there. And you can also see some ischemia in the retina. And the reason this patient needed treating very quickly was because this is starting to threaten the fovea there. You can just see the disease spreading across and affecting the fovea. And then the next slide is after treatment. So you can see it's all sort of melted away and quiet and behaving itself, which is very nice and satisfying. So now melanoma, this is a big worry to me. I'm very, very concerned at the moment, and I persist in being concerned that suspicious nevi are being referred in by optometrists on ERS. And that is just completely inappropriate. If it is a suspicious nevus, they must come to RAU. They must be referred down the emergency pathway. Because if, for example, you go in and you book or you're triaging and you book a melanoma for 6 weeks' time, that just simply isn't appropriate. This is cancer. This needs to come in very quickly. So if you see a nevus that you think is suspicious, and the suspicious features are those referred to in the mole score. So if you're seeing a mushroom shape of very elevated, if you're seeing orange pigment, if it's very large, if it's getting larger, and if there's subretinal fluid over it, they must be referred via the emergency pathway. Please, please, please do that, and don't send them via ERS. Just today, I had to I looked at a referral which had come in and had been triaged into ERS, and what I've done is I've gone into that patient's records, ordered a casualty appointment, but you can't rely on me doing that. This is a condition that can kill you. I mean, it's more than just a nasty condition. It's a condition that can kill you, and if you have a suspicious nevus, then send it via the RAU. If it is a melanoma, we will send it to Moorfields with an appropriate referral. If the patient is a known melanoma under Moorfields, please don't send it to us, send it to Moorfields. Because if the patient is under Moorfields, they are the oncology unit. So if you have a patient who says, yes, I had a melanoma, I had radiotherapy to my melanoma 3 years ago, and you think, whoa, hang on, this is all very elevated and there's fluid over it and everything, please then send that to Moorfields, because they will want to see their own patient. So if we could do the next slide for me. So this is a patient who was sent in as a suspicious nevus, and you can see why, because it's pretty big and it's quite elevated. Wasn't sure, but we would get an OCT over that, and please try if you can. It can be difficult, it can be challenging to get an OCT over the top of it. If we go to the next slide, you'll see it doesn't look terribly impressive, but if you can just see, if you look at you can see the elevation of the dome, and then you can see just over the top, there's just that little sliver of subretinal fluid. Even the sliver of subretinal fluid is a major red flag for us, and we would send that patient immediately to Moorfields. So we would be having a conversation about possible melanoma, referring on to Moorfields. So the key things with a query melanoma or a query, if you think a nevus is suspicious, if it's getting bigger, if you can do an OCT through it and you've got subretinal fluid, if it's got lipofuscin over the top of it, or if it's very elevated, please send it via the RAU pathway or to CRESS, where they are, and we will do the rest. But if it's a Moorfields patient who's had a known melanoma, please send direct to Moorfields. So next slide, please. And this is just a thank you to Neda and Laja and Sammy for all their help with it and their interesting images. So thanks very much.
Thank you, thank you, thank you. Sorry, I was talking away to you on mute. So I was just quickly repeat what I just said. Thank you very much, Ms. Richardson, for that talk, and all the pictures and images as well. So thank you to your team as well for those. There was a couple of questions. I'm just going to repeat it. When we talked about the CRAO and the BRAO, did you want to see those even if it's out of the 4-hour window? Oh, you're on mute, sorry.
Yeah, definitely. The reason for that is that the 4-hour window is basically the only time when we could consider treating them. And to be honest, I've never actually managed to get vision back in a CRAO. I mean, you can try all sorts of if I had a central retinal artery occlusion now and there was an ophthalmologist sitting next to me, they could do a paracentesis to reduce the pressure. They could give me Diamox. So you can eat. There's some form of rebreathing your own air, which I'm not quite sure what that does for you. It maybe calms the panic attack in the ophthalmologist. I'm not sure it does anything. But we would want to see them that day anyway, because we consider two good reasons. One is because we consider them a stroke, and the stroke team will need to get involved quickly. And the most important thing is to rule out GCA, because GCA is a condition that can blind you in both eyes and very quickly. So, there are times and Dana, sure at St Thomas's will have the same, where, I have seen a patient with a central retinal artery occlusion at Queen Mary's, and the registrar came down to clinic and said, I'm so worried about this lady. She's NPL in one eye, and we've got to protect the other eye. So we literally raided the cupboard and we're stuffing steroid tablets into her mouth before she went to main casualty, because obviously from us she's got to go to main casualty. She's not that we haven't got casualty there. So we were literally saying, take 60 milligrams of steroid, here you go. And now get in a taxi. So it is, yeah, definitely we would want to see them that day.
Okay. Miss Obi has her hand up. Thanks.
I was just going to make a comment about the massaging, and I have to admit, only once have I ever managed anything, and all we did was move a branch retinal artery occlusion a bit more peripheral. But I tell you, it took us 4 hours of paracentesis, acetazolamide massaging, and because we could see the embolus, we could see it moving away from one of the, from the sort of almost hemiretinal up a bit peripheral, and the person did report a little bit of improvement in the vision, but it took us 4 hours, because every time we tried to move them from the eye unit when I was at Kingston to the main A&E where they were going to get in, and when they were waiting for the patient would just say, oh, my vision's gone again, and it was this never-ending something. But most of them, as I say, you will see them, you don't do them any harm with a massage or give them some Diamox or lowering the pressure. No one's going to be doing paracentesis in a optometry practice, and most places I wouldn't even suggest that they do that. But massage and stuff may do something.
The other Bavina, you're on mute though at the minute. There you go. Thanks.
Hi, Miss Richardson. I just had a question then. With regards to Queen Mary's, if we were referring someone to you, but they also needed to go to the stroke unit, would it be better to send them to King's?
No,
you don't have an
send it to
A&E.
us, because because the stroke team will want us to make a diagnosis first.
Okay.
So send it to us, and then we have we will ring the medical registrar at the PRU and say, we've got somebody who has got a central retinal artery occlusion. Actually, we'll probably speak to the stroke team, and they have a triaging service, and you literally tick the boxes, and they say, this is a green light, they can wait till tomorrow. This is a amber light, and or the red light, grabbed by the ears and go straight in. So we've got a good pathway, Bavina. So don't worry, we're quite
Okay,
happy to do that.
perfect. Thank you.
Oh, just got to, I mean, the other thing they ask us to do is give them 300 milligrams of aspirin, as long as you know there are no major contraindications. So that's the other thing.
Perfect. Does anyone else have any questions? No. I have one question to raise actually, and it's to do with the suspect lesions and referring them into RAU, and obviously using that moles criteria. I was just going to ask whether the audience are aware of what the moles criteria and the actions that should be followed on the moles criteria grading scale should be, and where it is a 0 or a 1 that we should be monitoring and then referring in at the higher grades. Is that something people are familiar with? Do you need more information on moles or signposting? Then please let me know in the chat and I can make sure that information is distributed. There's a question about a nevus, actually. I'll just ask it if that's okay, Miss Richardson. If we see a lesion which we don't think is suspicious, but it is central, what would be an appropriate time to monitor that in community practice?
Well, if it just because it's central doesn't mean it's suspicious, I would say. I mean, if it's central, you should be able to get an OCT over it. And if it's, you can then see if it's raised, you can see if there's subretinal fluid over it. If either of those things, if it's very raised or very large, or if it's got subretinal fluid over it, send it in as an emergency.
Yeah. Excellent. Okay, thank you. Would you see a MAC off as an emergency?
Yep. Yeah, no, we would, because the sooner we see a detachment, the sooner we can repair a detachment. So MAC on is the most urgent. But if you sent me a referral today and said, I've got this patient and they've got a macular off detachment, their vision is count fingers, I'd triage that as see today, must be seen today. So yes, yeah, we would see them today. But MAC on are the ones that we really want to do as quick. We want to operate today because we want to keep the macula on. There's good evidence that the longer if we can keep the macula on, the visual potential of the eye after surgery is much better.
Brilliant. Thank you so much.
The only thing I was going to add is it's worthwhile trying to find out from the patient as much as you can how long the vision has been down. So because obviously there's a MAC off, it went off funny, about 2 days ago versus 3 weeks ago. You can be a bit more realistic with your expectation, and depending on how busy people are in the VR clinics or emergency something, they can triage appropriately and prioritize the ones who've had the shorter duration because they'll have the better outcome.
Yeah, brilliant.
And then if it's only eye or something like that, that's really really important to stress.
Absolutely. The more information that we have, the more information that the teams can work with to appropriately see them in that time scale. Right, I'm just going to stop recording. Thank you very much.